Hello, everyone, and thank you for joining us today. I want to start by thanking the organizing committee for letting me present and talk on this very interesting topic. And I'm excited to discuss where we are on carotid interventions today and in this management of carotid stenosis. So I don't have any disclosures pertinent to this presentation, and let's review the objectives of this talk. Our first objective is to review the pathogenesis and various modalities for evaluation of carotid stenosis. Then we want to review the currently available evidence for management of symptomatic and asymptomatic carotid disease. And lastly, we want to review the latest advances in medical as well as interventional management of carotid disease. So once you see a patient in the clinic or in the ED who has carotid stenosis, so how do you want to approach this patient? First of all, you want to see if the patient is symptomatic or asymptomatic, and at the same time, you want to see the degree of stenosis and how do you go about measuring the stenosis. Once you have this information, you want to decide if the patient needs only medical management or do they also need intervention. If they do need an intervention, what kind of intervention should be performed? And then how should we follow up the patient? So let's discuss some case scenarios. Dr. Azim, would you like to go through the case scenarios?
Thanks, Dr. Power. So as we go over these case scenarios, these are patients that we have seen within the past year at the University of Kentucky. And exactly like Dr. Powell said, we'd like you to think about the questions that were asked while we go over these cases. So the first case is a 58-year-old female, history of extensive vascular risk factors, and to throw into the mix alcoholic cirrhosis and substance abuse disorder as well. So in the fall of 2022, she came in with what seemed to be a TIA, acute onset right arm and leg weakness with resolution within 24 hours. Over the course of the next year, in 2023, she presented to the ED with dizziness, with hypotension, no really focal symptoms, no concerns for stroke-like symptoms. Next slide. Because she was presenting with so many symptoms, she presented to her primary care physician, who ordered a bilateral carotid ultrasound to be done. And we see the picture here. There is severe acoustic shadowing and a calcific plaque that was seen. Based on these images, she was then sent to vascular surgery, who got CTA imaging done. And we're showing you slides of her images from 2022. And as you can see, although the coronal makes it look a lot scarier than it actually was, there's a 50% stenosis in the left ICA. This was in 2022. Fast forward to 2024. Well, we can see both on the coronal, on the sagittal, and in the axial cuts of a CT angiogram that there is progressive stenosis. There is a 90% stenosis on the left internal carotid and 70% on the right side. So we want you to think about, is this currently symptomatic or asymptomatic? What do we do next? What are the steps do we take? Is this person a candidate for intervention? And if so, which intervention and when would you like this person to be followed up? So we'd like you to think about this as we move on to the next case. The next case is a 66-year-old male. Again, plenty of vascular risk factors, has a history of known cervical left ICA stenosis, presented with acute onset right-sided symptoms, so right-sided weakness and speech difficulty, came in as a stroke alert to our emergency department with a NIH stroke scale of 4. Since he presented within the treatment window, he received a thrombolytic, and the imaging at that time showed, as you can see on the axial, sagittal, and coronals, that there is a significant stenosis in the left ICA with what seems to be a soft plaque that was found. You can see on the sagittal a thin sliver of flow, so a near occlusive stenosis on the CT angiogram. An MRI was done, and as you can see here, there's restricted diffusion on the axial cuts. A digital subtraction angiogram followed and showed a 99% stenosis with a great picture of that trickle of flow, showing that 99% stenosis. And what also, that's the red arrow. And as you can see, in the course of the cervical left ICA, an intraluminal thrombus was actually seen as well. So the same questions again. Is this person symptomatic or asymptomatic? Are they a candidate for intervention? And what next? And to round this up, this is our last case, a 75-year-old lady, vascular risk factors again, had a coronary stenting, so was already on dual antiplatelet therapy. And along with that was a smoker of some repute. And of note, she had already undergone a right carotid stenting in the years prior. So she presented with recurrent episodes of right-sided arm and leg weakness, along with right-hand coordination. And it appears that the devil sometimes is in the details, that the only reason that her family noticed that she was suffering from these symptoms is because she was seen not to be smoking as much as she usually does, because she had trouble bringing her right arm to her lips. Her imaging showed a severe high-grade stenosis of the left internal carotid, as you can see in the axial sagittal and these coronal cuts. Again, try and think about whether this person is symptomatic or asymptomatic, and what steps do we take next. And to talk about what evidence we have in our decision making, I turn it over to Dr. Powell.
Thank you, Dr. Azim. I'm going to walk you guys through some background, some technical factors and some clinical trial evidence. And as we go through these slides, I want you guys to keep our case scenarios in mind and see how it fits into with the current evidence and whatever we are learning here. So to give you a background, we all know the pathogenesis of atherosclerosis. There is usually some injury to the endothelial lining of the blood vessel. And the factors which predispose you for endothelial injury are like a well-known hypertension, diabetes, kidney disease, lifestyle factors like cigarette smoking and dietary factors with high cholesterol, high fat diet, high carbohydrate diet. So once your endothelium is damaged, then it kind of paves the way for macrophages and leukocytes to infiltrate inside the endothelium and cause changes which will lead to formation of more increased collagen and elastin production and a formation of a fibrinous cap. In addition, there can be fat deposition or even hemorrhage and ulceration within this plaque, which can lead to formation of a thrombus on the ulcerated plaque. And these thrombi, superimposed thrombi, they can migrate and cause embolization into the intracranial circulation, causing acute ischemic stroke. So let's go over some definitions. So what is symptomatic carotid stenosis and what is asymptomatic carotid stenosis? Now, if a patient presents with a stroke or a transient ischemic attack or even monoocular visual deficits in the vessel which is affected by significant stenosis in the last 6 months, then this is labeled as symptomatic carotid stenosis. On the other hand, if there have been no symptoms for the last 6 months, and suppose the patient had a stroke on the affected territory on the side which shows stenosis 1 year ago, we will still call it asymptomatic carotid stenosis. So 6 months is the operative definition here. Plaques, they can be classified based upon their density. And the reason we want to talk about the density of plaques is because it helps us to decide if they're suitable for what kind of intervention, for endarterectomy or for stent placement. The plaques can look soft, where it is kind of hard to distinguish if this is actually a soft plaque or is it actually a superimposed thrombus on a smaller plaque which is ulcerated. So the soft plaques, if you measure the density on CT scan, it will be less than 50 Hounsfield units, whereas the plaques which have heavily calcified walls, they will have Hounsfield density of more than 120 HU. But most of the time, we don't actually go about measuring ROI, measuring these HU values. We kind of use it visually and see, hey, this is a heavily calcified plaque, or this is a calcified and mixed soft plaque, or totally soft plaque. And then there is a sonographic classification also of plaques, but this is kind of beyond the discussion of this current talk. There are a lot of details that we can go into plaque morphology. The important question clinically when you're seeing the patients is, how do you quantify carotid stenosis? How do you calculate the percentage? And two methods have been described. The most widely used is the NASCET, or the North American Symptomatic Endarterectomy Trial, the methodology that NASCET authors use, that is used most widely. And in this method, you measure the narrowest part of the vessel And narrowest means like our vessels, they are like an oval. So they may look bigger in one dimension than in the other dimension. You still have to measure the narrowest point of the vessel as shown by the measurement B in this graphic. And then you take the measure of the vessel distal to that, where it looks normal. So don't take it immediately after the plaque, because there is normally some dilatation in the region of the carotid bulb, but you have to go a little distally and see where the blood vessel caliber looks normal. And this ratio will give you the degree of stenosis. Now, what about vessels which are severely stenosed, and they are so stenosed there is not enough blood flowing through the blood vessel, and the vessel distally, it kind of just looks like overall it is diminished in caliber. In those cases, we assume that this is definitely more than 90% stenosis or critical stenosis. Now, this is compared to the European methodology of measurement, as they measured in the ECST trial. And in this trial, again, they measured the narrowest part of the vessel in the region of the atherosclerotic disease. And the denominator was the projected normal caliber of the vessel at the same level. And notice that the NACET dimensions, they don't really match the ECST dimensions. There is significant variation. A NACET stenosis of 30%, maybe 50% stenosis in the ECST criteria. But mostly clinical practice, it's an NACET criteria that we use worldwide. And that is why in many radiology reports, you will also see that they will mention this is 50% stenosis as per the NACET criteria. So our discussion will focus on the basis of the NACET criteria. And then let's discuss the imaging modalities that we used in evaluation of carotid stenosis. And we will start with the basic one, which is the carotid ultrasound. Almost any patient with vascular disease will get this investigation done. And it helps to characterize the plaque. It helps you to see if it has calcified areas. It has, like, for example, in this particular picture, you can see that there is this heavy acoustic shadowing, which means that this area of the plaque is calcified. And behind that, you only see dark shadow. That tells me that this is heavy calcium. And some plaques may look softer. The important thing to remember is that the stenotic vessels, when blood passes through them, it is going to look turbulent. It's not going to be a streamlined flow. And that translates into multicolored flow signal, as you are seeing here. And also, we need to remember that if the velocity, we are able to measure the velocity of blood throwing the area of interest, blood passing through the area of interest. And if this velocity is more than the peak systolic velocity in the area of interest is more than 230 centimeters per second, then this is usually more than 70% stenosis. And if the peak systolic velocity is less than 125 centimeters per second, this is usually a normal caliber vessel. So anything in between would be 50 to 69% stenosis. So what I want you guys to take away from this talk is to remember the number 230 when you're looking at your Doppler report. If it says, or even when you're scrolling through pictures on the side, you will see there will be a measurement, and look at PSV more than 230, you will know immediately this is severe stenosis. Additional parameters have been described, but these are the ones which are most commonly used in routine clinical practice and easy to kind of quickly evaluate. And here in this graph, you can see that the authors correlated the degree of stenosis with the angiographic diameter with the peak systolic velocity as seen on carotid Doppler. And you can see that as the velocities increase, the degree of stenosis increases, and around 230, 250, that is where you have your significant stenosis of around 70%. And obviously, as the stenosis keeps increasing, at some point, there will be no flow through the blood vessel, and then the velocities will be zero. But the higher velocities, 230, 250, 350, 300, they all indicate hemodynamically significant stenosis. What is the role of CT angiogram? Most patients, after getting a Doppler evaluation, will get a CT angiogram. We want to get a CT angiogram of the head as well as the neck. In the CT angiogram of the neck, obviously, we will measure the degree of stenosis. Here, we can see the complete wall of the blood vessel as a complete oval. And I would recommend making your measurements on the axial planes, because axial planes are the kind of ground truth. The sagittal and the coronal images, they are reconstructed from the axial planes. So there is some element of volume averaging where the thick slides are superimposed on each other. So that kind of like induces a degree of error. So, and also in the smallest dimension, in the axial pictures, you should find the area which has the smallest dimension. Like, for example, in this particular picture, you could measure it like from right to left, or you could measure this vessel lumen from anterior to posterior. Since anterior to posterior is the smaller dimension, that would be the area, that is the dimension we will take for measurement of stenosis. And then we go higher up and we find wherever the normal caliber of the vessel is resumed, that would be the denominator for measuring the degree of stenosis. Now on CTA, the other advantage is that you can see the bones, so you can definitely see what is the level of bifurcation. And again, this goes into the decision making when we are trying to decide what would be a suitable intervention for the patient. So on CTA, we are looking at the caliber of the vessels, we are looking at the level of bifurcation, we are evaluating the kind of plaque, whether it's heavily calcified plaque or soft plaque. We also try to look at the angle of the mandible, which will again factor into decision making on how we want to proceed for this patient. And always take a look at CTA head, because CTA head will show if the patient has intracranial atherosclerotic disease, if there is any moya-moya phenomenon. Again, all those factors will decide how you want to move forward with the patient. Cerebral angiography is the gold standard for measurement of carotid stenosis. It is the most specific test, but it is also the most invasive test because you have to go through radial or femoral route, and then you have to go inside the vessels, inject dye, and the patient needs sedation. So, but the degree of stenosis, as you can see in this particular example, there is severe stenosis, and there is just a trickle of contrast going through. And you can see even in the trickle of contrast going through, there is an internal filling defect here, which is the floating thrombus within. And here you can see that there is stasis of flow. Like on CT angiogram images, you will see contrast opacification or no opacification. You don't get information about the flow. In this particular image, you can see that the contrast is flowing faster in this external carotid artery branches, which are going towards the face, whereas the internal carotid artery branch is filling up later. And so we know that this is causing significant stasis, and there is limitation of flow to the brain parenchyma. So you get flow information too. The disadvantage is that you don't see plaque thickness. The plaque thickness you evaluate much better on ultrasound and CT angiogram examinations. Now, let's review some currently available evidence. We will start in the 1990s when the first trial came out, which was the NASA trial. And in the NASA trial, it compared if the surgical procedure of carotid endarterectomy, or CEA, reduces the risk of stroke in patients who are symptomatic. And this trial was conducted in 50 centers across North America, and the patients were randomized to two arms. One arm received only medical management, and the medical management was aspirin, along with a statin, along with management of diabetes and hypertension. And the surgical arm received both the medications as well as underwent CEA. And these patients were less than 80 years of age, and the patients were assessed for perioperative stroke adverse events at 30 days and also stroke severity at 90 days. The goal of this trial was to recruit around 1,200 patients, but it was stopped prematurely when they had recruited around 650 patients. Why? Because they found that there was a clear difference in the benefit in the surgical arm compared to the medical management only arm. There was an absolute risk reduction of ipsilateral stroke, or by 17% in the surgical arm compared to the medical arm. And they found that the number needed to treat was 15. So therefore, this trial concluded that CEA is very beneficial to patients with recent hemicephalic or retinal strokes and ipsilateral high-grade stenosis. The high-grade stenosis was stenosis greater than 70%. Now, this study was continued up to 1998, where they kept recruiting patients who also had stenosis, say, between 30 to 69% range. And they also kept following up the patients who had severe stenosis and had undergone carotid endarterectomy. These patients were followed up long-term till 1998. And the data that came out in 1998 showed that the patient with severe stenosis, after follow-up for 8 years, continued to derive benefits, and they had lower risk of stroke and adverse events compared to patients who underwent only medical management. And also in patients who had moderate stenosis, which was 50 to 69% stenosis, did derive benefit from going through surgical arm compared to only medical arm, although this benefit was less modest compared to, it was more modest compared to patients who had severe symptomatic stenosis. The next trials that came out were for trials for management, for comparison of surgical management versus only medical management in asymptomatic stenosis. And the major trial was the ACAS trial, or the asymptomatic carotid atherosclerosis study trial in 1995. And here the question was patients who have greater than 60% stenosis, but they are asymptomatic, how do they fare if they are randomized to only medical therapy versus medical therapy with carotid endarterectomy. So they found, if you focus on this findings tab, they found that the incidence of stroke or mortality was halved in the patients who received surgery in addition to medication compared to the patients who only received medical management. And this was statistically significant. However, the caveat here was that these patients should not have other significant comorbidities, which put them at high risk of peri-procedural complications. So the conclusion was that patients who have asymptomatic stenosis but have greater than 60% narrowing and have a good perioperative and they have good surgical risk criteria, the risk of ipsilateral stroke decreases by half in these patients if they undergo surgical management compared to medical management alone. And the number needed to treat based on this trial was 19 to 50. And then, so now here we have to remember that carotid endarterectomy is a procedure which was first performed in 1954, whereas carotid artery stenting and angioplasty procedures were first done in the 1980s. So at the time when these initial trials came out, the carotid artery stent procedure was just maybe 10 to 20 years old, whereas CEA was already 30 to 40 years old, well-established procedure. So people who were going through CAS, who were performing CAS, were still kind of going through a learning curve, and the devices that were available were also not as sophisticated. So all the initial trials which compared carotid artery stenting to carotid endarterectomy in patients who did not have high surgical risk found that carotid artery stenting was non-inferior to CEA. However, all these trials found that the risk of stroke, ipsilateral stroke in the peri-procedure period was much higher in patients who underwent stenting compared to CEA. And the most important trial here is the CREST trial, the results came out in 2010. And in this trial, they found that in patients, whether they were symptomatic or asymptomatic, the patients who underwent stenting, they had a 6% risk of peri-procedure stroke within 30 days compared to 3.2% with CEA. However, once you cross those 30 days, the results between CEA as well as stenting were very similar. One was not performing better than the other, and the complication rates were also very similar. So people who are the critiques of carotid artery stenting said that that 6% number is really high. It was statistically significant, and you have to cross those 30 days to get the long-term benefits. So maybe it is not reasonable to perform carotid stenting in patients who are otherwise suitable for CEA. And that is why it was defined, and I'm going to go, sorry, I will come back to this later when we discuss the results of ACST2 trial, which came out in 2020. So as you can see, this trial started recruiting in 2008, and the results were published in 2020. This trial continued to recruit asymptomatic patients over a period of 12 years in 33 countries across 130 centers. So now we are like in 2000s, which means even the carotid artery stenting procedure is now well established for 30 years. We have newer devices, operators are more experienced, they have better training. And in this trial, they found that the procedural risk for both CEA as well as carotid artery stenting in the first 30 days was 1%. So that shows you how far we have come when it comes to interventions. And then again, they found that both stenting as well as CEA provided benefit in major stroke and following up for 5 years. So another ongoing trial is the CREST-2 trial. And then again, this trial started recruiting patients in 2014. And here the target was 1,240 patients. We are still awaiting the results with great anticipation. In this trial, patients are randomized to receive either carotid endarterectomy or stenting, and the patients who are randomized to the stent arm with medical therapy are compared against only medical therapy, and in the other arm, the patients who are undergoing CEA with medical therapy are also compared to patients getting only medical therapy. The big difference in this trial compared to previous trials is that the targeted therapy here is very strictly managed, and also the lifestyle interventions are also very intensively like there are lifestyle coaches who are going to work with the patients to make sure that their diabetes is controlled, that they are physically active. Whereas in previous trials, it was just like, here, take your aspirin, take your diabetes medication, take your hypertensive medication. So here the medical management is much more involved, much more engaged. And similarly, the operators who are authorized to perform a stenting procedure, they are all highly skilled operators, and they have to have fulfill certain criteria. So this trial results we are waiting to see what they will show as hopefully the next couple of years. So now that we have discussed a little bit about the medical management and surgical management trial, I will pass this back to Dr. Asim to discuss the medical management of patients with carotid stenosis and what are the goals we are aiming for here.
Thanks, Dr. Powell. So as Dr. Powell said, the benefit that we have seen, any known benefit is in the context of correction of vascular risk factors. And in recent times, we have a better quantification, a better consolidation and establishment of clear targets. So it's target driven, it's goal directed. It's not arbitrary numbers anymore, and we have certain evidence to actually prove that. So the big vascular risk factors need to be corrected. So we start from the bottom up. So blood pressure was first on the list. There's cholesterol management, especially with LDL, lifestyle management, especially with physical activity, and then you have to consider the comorbidities, heart failure, kidney disease, prior strokes, and diabetes mellitus as well. The cardiology has done a lot of work on this in the past, and the numbers that you will see as targets will be either 130 over 80 millimeters of mercury, or there are some studies as well that have 130 over 85. One important thing to consider is intensive blood pressure management. It's important because it avoids the irregular fluctuations in blood pressure. And the better your blood pressure is managed, it reduces the risk of orthostatic hypotension, hypertensive events, lesser perfusion through those stenotic vessels, and those fluctuations, the avoidance of fluctuations has been known to reduce the risk of cerebrovascular events in the future. Another great study that was done, this was the carotid occlusion surgery study. This basically divided patients into two groups with blood pressures that were maintained below 130 over 85 millimeters of mercury, and then the other group that were above. And as you can see, the vertical lines are the systolics and diastolics, with the black marked lines being stroke events that actually happen in those patient groups. There was a total of 91 participants, and as you can see, as the blood pressure starts to increase, there's more rate of ischemic events happening in these patients. Another big factor is cholesterol management, and especially with low-density lipoprotein. A study that was done involved above 2,800 patients that had a stroke within the past 3 months or a TIA within the past 2 weeks with a known atherosclerotic disease. And they randomized them to a target LDL of less than 70 versus less than 100. And the primary endpoints were either a stroke, a myocardial infarction, any cerebrovascular or cardiovascular event that needed a revascularization procedure involving the carotid or the coronary arteries, or death. And the study basically showed that the chance of these primary endpoints and the risk of it was much lesser in the group that targeted LDL levels of less than 70, as you can see with the orange silhouette giving you the thumbs up. And as of 2015, we have new agents on the market as well, especially with people who are allergic or have adverse effects to the HMG-CoA reductase inhibitors. We now have the PCSK9s, which are a powerful agent, alirocumab and evolocumab. The studies that came out were the Odyssey Outcomes trial, had close to 19,000 patients that were followed up close to 3 years. And the primary endpoint showed that the incidence showed that there was a reduction in events on people who. So the big factor was that patients who were on statin therapy, who had a history of atherosclerotic disease, the patients who were put on a PCSK9 inhibitor had a lesser rate of cerebrovascular events. And these were FDA approved in 2015. A very big factor that we recently brought into consideration, and this is on the Sampras trial, a fan favorite of the residents here, which we like to invoke in a lot of our stroke alerts, is physical activity. a post hoc analysis of the Sampras trial that was basically symptomatic intracranial stenosis with patients more than 70%, so high-grade stenosis. They found that physical activity was actually the strongest predictor of a good outcome in the medical arm, and the randomization was maximal medical management versus intracranial stenting, and it was overwhelmingly in favor of the medical management. The post hoc analysis also showed that physical inactivity led to 5 times the likelihood of having a stroke, a myocardial infarction, or death due to these vascular events. And then to round out the other lifestyle factors, we take this as common sense, but there is a lot of work that has gone into it. Big factors, of course, we talked about physical activity. Diet is a very big factor, especially if you are hypertensive or have type 2 diabetes or type 1 for that matter. And then smoking cessation makes a big difference. So counseling, grassroots care, and advising your patients to maintain healthy lifestyle habits is a very big factor in good outcomes.
Okay, thank you so much for that great overview of medical management. And now, since we've been talking about procedures, let's shift gears and talk about the procedures a little bit in more detail. And here I'm going to show you kind of the steps of carotid endarterectomy, CEA. So in this first picture, we can see that the surgeon has made an incision in the neck, and after that, they have dissected through the fascia, muscles, and they have gone through the carotid sheath and exposed the carotid bifurcation. This I hope my arrow is visible. This in the bottom half on the right side of the picture is the common carotid artery. Then on the top, this is the anterior one is the external carotid artery, and the posterior one is the internal carotid artery. And in the beginning of this procedure, after these vessels have been separated out, the surgeon will place these loops, as you can see, these white loops around each of these vessels, and then tie them up in order to cause flow arrest. So throughout the procedure, there is no blood flowing through the carotid vessel, and the brain relies on collateral circulation from the opposite ICA and from the posterior circulation and ECA collaterals to supply that side of the brain. So these vessels are kind of like closed off for the duration of the procedure. In this second picture, you can see that the loops are still tied there. The surgeon has kind of nicked through the wall of the vessel, and here the yellow structure that you see here is the plaque. And in the next picture here, you can see that the plaque is being taken out. It's kind of being delivered from the vessel wall. And here you can see that the vessel wall, we can see the clean looking underlying intima, the yellow plaque and the calcified plaque has been taken out. The next step is to put in a graft where the incision was made. And here you can see that the graft is being sewn in. The vessels are still kind of like closed off by these vascular loops. And finally, in this final step, you can see those white vascular loops, they have been released. The blood is flowing through the blood vessels now. And the graft is kind of in place. So knowing this background of surgery will help us decide when do we offer patients endarterectomy and when do we offer patients stenting based upon some of the factors, anatomical factors. So first of all, since all carotid endarterectomy procedures need general anesthesia, these patients should not have high-risk cardiac or pulmonary comorbidity factors, which can increase the risk of intraprocedural surgical complications. So the second thing is that heavily calcified plaques, they are, when you give an incision through the vessel, they are very easy to scoop out and deliver. And these calcified plaques, if you try to open them with a balloon, they will want to kind of like relapse back and cause stenosis again. So calcified plaques are more suitable for CEA compared to carotid artery stenosis. And now carotid artery stenting. Now, and if you go back to these images, you can see that you are putting in order to achieve flow arrest, you have to kind of like stop the flow in the vessel. You have to have access to the vessel at the common carotid artery below the bifurcation and ICA and ECA above the bifurcation. And because you have caused flow arrest by blocking off these vessels, you're also preventing any emboli from propagating distally during the surgery. And that is the main reason the complications of CEA traditionally have been lower than that of stenting. So if you have a carotid bifurcation, which is the most common location is below C3, C4 level, below the angle of the mandible. So if the bifurcation is below the angle of the mandible, you are able to expose that area very nicely, and you are able to deliver the plaque and suture up the vessels, and it does really well. On the other hand, patients who do not have this favorable anatomy, where the bifurcation is above the level of mandible. So if the bifurcation is above the level of the mandible, in order to get complete surgical exposure, you will have to dislocate the mandible. And that brings its own problems for the patients in post-procedure complications. So that, and also it's surgically more difficult. So most surgeons don't like doing this. Similarly, if your carotid bifurcation is below the level of the clavicle, again, you have to do a sternotomy, dig through the clavicle to get access to that area. And again, which is not a fun procedure to do. So those patients are not good candidates for CEA, but they're good for carotid artery stenting. Similarly, patients who have already been through CEA or patients who have had radiation for malignancies, those vessels are very friable and they're not going to take sutures very well. Those patients are more favorable for putting in a carotid stent. A patient who has contralateral occlusion, say you want to do operate on the right side and the left side is already chronically occluded. Because in carotid artery stent, sorry, because in CEA, you are putting these loops to shut off the blood supply. And if the other side is also completely blocked, the patient has higher risk of complications. And these patients would be more suitable for a carotid stent placement rather than CEA. Similarly, patients with laryngeal nerve palsy, because carotid sheath is closely related to the 9th, 10th, 11th nerves, patients who already have a palsy, if we, on the contralateral side, and if you want to do a CEA, you can risk injury to the 10th nerve on that side too, and that can make things worse for the patients. And this patient would be more suitable for carotid stenting. And patients who have severe risk factors like lung disease, kidney disease, very old patients who are high surgical risks, CAS can also be performed under moderate anesthesia care, so you don't need full general anesthesia. So these patients would do better with carotid artery stenting. And because in carotid artery stenting, you have to you're putting a catheter inside the blood vessel and going from inside the aorta, and then you're selecting the vessels in the neck. So patients who, the vessels which are very tortuous, or the vessels which are like very, what should I say, irregular or sagging, those vessels are more prone to dissection when you're passing catheters and wires through. And then those patients are not suitable for stenting, they are more suitable for CEA. So so in a way, you can see that these procedures are kind of complementary. One is some patients are more suitable for one, the others are more suitable for the other procedure. Now here I will show you some pictures of the carotid artery stent procedure. This is the initial picture where you can see the catheter is in the common carotid artery. This is the carotid bifurcation. You can see that this part, the proximal ICA, is narrow compared to the distal part. And you can also see an outpouching here. This outpouching is kind of like an ulcerated plaque. And now in this step, we have our base catheter in the common carotid artery. This little 3 dots is the distal protection device, which is an umbrella like a device, and this umbrella is supposed to catch any debris which can fly off when we try to do an angioplasty at the site of stenosis. And angioplasty that is done is always done sequentially. You start off with a small balloon, open it up a little, then you go with a bigger balloon, open it up a little more. All this while this umbrella-like distal protection device is in place and will catch any debris that can fly off and prevent non-target embolization. And finally, you place a stent, you remove the balloon, you place the stent, you remove the distal protection device, and you restore flow during and the caliber, as you can see, is improved compared to the initial pictures. So this is kind of a brief overview of the stenting procedure. Now, what are the complications? Both procedures, during the procedures, the patients can have heart attacks, they can have stroke because of embolization of the plaque material. Massive strokes or heart attacks can lead to death, bleeding, and cranial nerve injuries. These are more complications of CEA compared to stenting. Restenosis can happen with any procedure if the patient continues to not modify the lifestyle factors or other vascular risk factors. You will see that from time to time. A brief overview of TCAR. TCAR is a procedure which kind of is supposed to combine the benefits of CEA as well as stenting. It's called transcarotid artery revascularization. And in this particular diagram, you can see that while the surgeon is trying to place the stent in the carotid artery across the stenosis, the device has an attachment which is going to cause reversal of flow from the carotid artery. And this blood is going to flow through this filter, which is going to remove any plaques or debris which have dislodged while performing angioplasty. And then this blood is returned into the femoral vein, and then it goes back into the circulation. So TCAR has come up in the last like 10, 15, 20 years. It is FDA approved. However, there are no prospective randomized clinical trials for TCAR. We have prospective studies and registries, and there is a large amount of data. And this, for example, Roadster 1 and Roadster 2 trials, if you want to look up, you can look up in detail. And these trials have shown that the procedure is as effective as CEA and transfemoral carotid stenting in decreasing the risk of stroke, disabling stroke, or death in patients with significant stenosis, and their complication rate is considered comparable to CEA. However, the big thing is that they don't have clinical trials data. This is large prospective registry studies. So and then we are going to come back, revisit this ACST2 trial, which I discussed briefly earlier. The trial results came out in 2020, and the main reason we would say that CEA is better than stenting in most patients because the CEA has lesser risk of perioperative stroke, and stenting predisposes patients in the first 30 days to have major strokes. The difference is significant, and so only if the patient is high risk for CEA should they undergo stenting placement. So up till October 2023, those were the guidelines. We would discuss with each other, hey, is this with our stroke neurologist, with the patient, with the vascular surgeon or neurosurgeon, whoever does CEAs at your institution, that does this look suitable for stenting, or is it high risk for CEA? Then I will take this patient up for stenting. But after the study came out, the data from ACST2 trial was so overwhelmingly favorable to show that the procedural risk is around 1% for both CEA and stenting. Like I was mentioning earlier, the procedure has come a long way. Stenting has come a long way. We have better devices, very experienced operators. And the data in this trial was 3,600 patients almost. And before that, the data that we had available was around 3,000 patients. So this trial doubled the data we had for asymptomatic carotid patients. And so therefore, these numbers are like very significant. And once this trial came out, there was in October 2023, CMS expanded the coverage for carotid artery stenting. What does that mean? So initially, carotid artery stenting, as I was telling you, was only approved for patients who are high risk for CEA, or if you want to use it in patients who are not high risk for CEA, you should be part of a clinical trial. But now, starting October 2023, this requirement is no longer there. Even patients who are regular surgical risk, are not high surgical risk individuals, they can undergo carotid artery stenting. So how do we decide who are the groups of the patients who are covered now? Patients who are symptomatic and have carotid stenosis of greater than 50%, and patients who are asymptomatic but have carotid stenosis of more than 70%. This is kind of aggregation of all the data we have, all the evidence we have since 1990s. And the patient has been evaluated by a neurologist or an NIH certified health professional, has been evaluated by an ultrasound exam, by CTA or MRA to look at the aortic arch, neck vessels, as well as the intracranial circulation. And catheter angiography, the digital subtraction angiography, should be performed only when there is discrepancy between these two modalities. Otherwise, you need not perform this angiography for every patient. So once you have all this information, then then you can have a discussion with the patient. You have had a discussion in a multidisciplinary team with a neurologist, with a neurosurgeon, vascular surgeon, radiologist, and then you talk to the patient. Hey, suppose say the patient is 75 years of age, and they have very tortuous vessels, and we know that tortuous vessels will increase the risk for embolization if you're trying to put in a stent. And say their bifurcation is in a normal location, the surgeon can easily expose. So then this patient would be suitable for CEA. On the other hand, if the patient has a history of prior radiation therapy, then they can be suitable for carotid artery stenting. And you offer all these options to the patient, you discuss with them, and then based on that, the patient is able to decide which procedure they want to go through. So you have to incorporate the beneficiary's personal preferences too. And this is all included on the CMS website if you go through this. So let's revisit our case scenarios. Our first patient was a 58-year-old lady with multiple vascular risk factors, substance abuse, tobacco abuse. She had TIAs in 2022. And after that, on repeated visits. She came for hypotension, but no focal deficits. So she did not have any new TIAs or any new events. And we already saw that the Doppler showed significant stenosis with turbulent flow in the artery and calcified plaque. And in 2022 imaging compared to 2024 imaging, there was significant progression of atherosclerotic disease. And here you can see at the bifurcation, the plaque is very heavily calcified. So this is progressive stenosis, even by measurements. And this is all predominantly calcified plaque. So now we were asking earlier, is this patient symptomatic or asymptomatic? So going back to our definition, if the patient has not had any ischemic event, any focal neurological deficit, like a TI or a stroke in the last 6 months, then they are considered asymptomatic. So this patient is asymptomatic. However, her stenosis is more than 90%, and she's 90% symptomatic, asymptomatic. So, and she has a heavily calcified plaque. And if you go back and look at her anatomy, this is her carotid bifurcation. This is at, say, C4-5 level. This is C2, 3, 4, 5, C5-ish level, 5, 6 level. And this is the level of the mandible. So this is below the level of mandible. And as I had mentioned earlier, that calcified plaques, they do not respond well to balloon angioplasty. So this patient underwent a carotid endarterectomy. And this is the plaque, as you can see. I borrowed this case from one of my partners who does these surgeries. So when should you do these procedures? You should do them as early as possible, because the highest benefit for carotid interventions, like this patient has 90% stenosis, so they are at a very high risk of ipsilateral stroke. And so the patient came at first available appointment, and on 4-week follow-up, they were back to your normal physical activities, did not have any complaints. They did really well. Now, going on to our second case, this was a 66-year-old gentleman, had a known left ICA stenosis, came with aphasia and right-sided weakness, NIH of 4. Because his NIH was 4, he did not undergo thrombectomy. But as you can see in these images, this is the right-sided carotid artery, ICA. This is the left-sided ICA. In all these three images, axial, sagittal, and coronal, you can see that there is kind of an abrupt cutoff of the vessel, and there is very little thin streak of contrast which is passing further up into the vessel, and the rest of the vessel lumen is not opacifying. So this patient is symptomatic, and there is kind of critical stenosis with possibly superimposed thrombus. On MRI also, you can see that there are areas of diffusion restriction, and here we have seen this picture before in this presentation, that there is a floating thrombus here with critical stenosis, and as I had mentioned earlier, your ICA should fill faster than your face vessels. Here you can see the face vessels, the ECA branches are very well opacified, whereas your ICA is filling in a very delayed fashion. This is the distal cervical ICA, and the contrast has washed out from the ECA branches, and this is still filling. This shows you the flow is very, very slow. Slow. So in this patient, clearly he's symptomatic, but because he has this large floating thrombus, if we try to do any intervention at this point, we have a very high risk that this thrombus is going to break off. A smaller piece can go very distally and lodge in a branch that we cannot retrieve and cause worsening of symptoms. So at this point of time, we are not jumping to intervention. We are actually going to go for medical management. So this patient did get heparin. He was discharged on dual antiplatelet therapy and statin. And then he came back to the clinic within 4 weeks. And then this patient also underwent carotid endarterectomy. And he's doing well, apart from some residual world-wide difficulty, back to remodeling houses. Our third patient, as we had discussed, she already had received a right-sided carotid stent, was on antiplatelet therapy. She also had a history of breast cancer, had undergone radiation, and she continued to smoke. So here again, as we said, her right-sided weakness was noticed because sometimes she would not be able to lift up her hand to smoke. So they noticed there were these episodes where she was not able to do that. And on CTA, we can see there is a soft plaque as well as calcified plaque, which is causing severe stenosis. The lumen is really, really narrow. Same thing is seen on sagittal and coronal images. So this is her again, the question is she symptomatic or asymptomatic? And these are the angiographic images. She's clearly symptomatic because she has these episodes of TIA which are attributable to the left cerebral hemisphere, episodes of weakness. And here on the angiogram, you can see that there is this area of stenosis in the proximal ICA, and there is this ulcerated plaque where you can see the outpouching of the contrast. And here we have done some measurements. Here you can see that the measurement, they probably won't show through very well, but the most stenotic area is less than 1 millimeter in size. It is 0.8 millimeter, and the distally it is around 3.5 millimeter. So normally carotid arteries are 4 to 5 millimeter in size in most patients. So if this vessel is measuring less than 4 millimeter in size, probably this is close to 80-90% stenosis, high-grade stenosis. So in this case, I think we had discussed these images earlier. We can see that we have a catheter in place in the common carotid artery. We have a distal embolic protection device in place distally in the cervical ICA, and we have done sequential angioplasty. We start with a smaller balloon, inflate in the area of the plaque, then we go on with a bigger balloon. Here in this balloon, you can see a little waste. This is the region of the stenosis where it's trying to break through the plaque. And finally, we were able to place a stent. And you can see there is interval improvement in caliber, and the area of ulcerated plaque is now also completely covered by the stent. And the stent will kind of form a scaffold for the vessel to endothelialize and heal. So this patient is on continuous dual antiplatelet therapy and high energy statin, but as you would expect, she continues to smoke. But on follow-up, she's doing well. She does not have any symptoms as of now. So to summarize, target-driven medical therapy and carotid interventions, they reduce long-term stroke risk in patients with significant carotid stenosis, significant meaning greater than 50%, and it can be symptomatic or asymptomatic stenosis. For symptomatic stenosis, we want to intervene when the stenosis is greater than 50%. For asymptomatic stenosis, we want to intervene when the stenosis is greater than 70%. Both endarterectomy and stenting are safe and effective procedures. And as per CMS guidelines, TCAR is considered similar as transfemoral carotid stenting. So both procedures, all three procedures can be offered to the patients depending upon their anatomy, their comorbidities, even the surgeon experience, the local practice patterns, and they should be offered, and they have similar perioperative risks and have long-term benefits. These are the references, and thank you so much for your time. I'm happy to answer any questions.
Dr. Pawa, there are a couple of questions that I wanted you to address. The first one is, how can patients with carotid stenosis manage their daily activities while minimizing stroke risk?
That's a good question. I think that is applicable to all of us. You're right. So how do we manage our daily activities? Like they say, you have to increase, you have to switch. It's a kind of a lifestyle change. You have to switch over from you have to switch over from a sedentary lifestyle to a more active lifestyle, like, for example, everybody says these things, go for a walk, try to park your car away from where you're supposed to be, so that try to climb some stairs. So even little things will go a long way. But I feel that when you have so many risk factors, probably, you're not doing these things, and there are some barriers because of which you're not able to do these things. So it is very helpful to have a comprehensive center where there are multidisciplinary teams. There is a dietitian, there is a health fitness coaches there who are working with the patient to identify these barriers, and then see how they can make this lifestyle change. This is going to be a long-term change. They're going to need continuous reinforcements. They will have to have follow-up visits. So, like, habits and lifestyles are very, very hard to change. So this has to be a very ongoing process, which my job as an interventionist is to make sure that the patient gets these referrals. And similarly, when a stroke neurologist sees these patients for follow-up, they want to make sure that they get these referrals. And at every time I see patients yearly for follow-ups once they get an intervention, or if they have a stenosis, but they are asymptomatic, don't fit the criteria for intervention, I follow them up on a yearly basis. So I check with them, hey, are you going to your PCP? Are you doing these things? Are you still seeing this? Are you managing your weight? So all those, it's truly a team effort. And every place which is managing carotid disease should try to kind of set up these multidisciplinary teams which can help the patient.
Thanks, Dr. Pawa. There's a couple more that have come in. The next one reads, are there any ongoing clinical trials for carotid stenosis treatment?
CREST-2 is ongoing, and we are waiting for results on that. That is the biggest trial that we are waiting for in the next couple of days. I think they have achieved a good number of surgical candidates. They are waiting for some more stenting candidates, more stent subjects to be recruited, but those results should be coming out pretty soon.
Great, thank you. There's another question that says, are there any patient advocacy groups or resources that are available for those with carotid stenosis?
I'm pretty sure AHA, if you go to any of these websites, American Heart Association, American Stroke Association, they have a lot of resources. So what we can do from our clinic standpoint is that they have those pamphlets and booklets which can be printed out, and you can work with your clinic management to get those printed out. You can be given as handoffs to the patients. And American Heart Association also brings out patient stories. From time to time, they have events, patients who recovered from stroke. And if you follow them on social media, also, there's always something going on. So if you follow AHA and other society committees, you will find a lot of resources that you can hand over to your patients.
And another question, it reads, sometimes we deal with a cardiac patient who has presented with stroke and has symptomatic carotid artery stenosis. What is the best modality in this case if they have heart failure as well?
Are we meaning modality as for diagnosis or for treatment? I'm
For
assuming
intervention is what
for
I'm assuming.
intervention. So if a patients have significant cardiac um, comorbidity, we would prefer to do carotid artery stenting, because patients with other morbidities, they have higher complication rates with CEA compared to stenting. So this patient would be more suitable for stenting if the plaque is favorable. Even if, say, a patient has poor ejection fraction and is high risk for surgery, even if the plaque is calcified, we do the angioplasty. It will not be as good a result as you would get with the CEA, but you would still get improvement in vessel caliber. So basically, you have to balance the risk of the procedure with the risk of how bad the stenosis is and what the plaque looks like and what are the chances of complication with the procedure itself. And that is why you need to have multidisciplinary teams. You have to talk to, so I'm an interventional radiologist, so I'm not going to do carotid artery endarterectomy. So I talk to my surgery partners and I talk to them, hey, what do you think about this patient? If you had to do CEA, his plaque is calcified. I don't think this is going to respond well to angioplasty, but he also has multiple other risk factors. They would say, oh, no, this patient is fine. I think I can take him up for CEA, or no, this he looks bad. I think I don't want to put him under the knife and open this. So okay, fine, we'll take them up for stenting. But we do talk to the patients that, hey, given these factors, your chances are risk factors are slightly of complications can be slightly higher. But if you don't do it, then the chances of stroke are this much. So you have to take all these factors. It's a very individual patient to patient basis. But if I had to give an answer, the patient has cardiac disease, poor ejection fraction, and has a plaque, which is not super calcified, I would say that, okay, this patient is more suitable for stenting rather than CEA, if it was to be a short answer.
Thanks, Dr. Pava. I think with that,
I see one more question.
oh, there's another one that came in. Yeah.
Yeah, if a patient has bilateral 99% stenosis, what will be suitable modality? This is easy because we talk about that. Again, we go back to what do we do in CEA and what do we do in stenting. In CEA, you have to tie those loops around the vessels, which is going to cause complete flow arrest on that side. So if there is complete flow arrest and the other side is also 99% stenosed, this means that the patient is not going to get enough blood and they can have intra-procedural stroke. Whereas when we are doing the stenting part, we are not closing off any vessel. We are crossing the stenosis. The other side is still fully open as it is. So these are the patients who will do better with stenting rather than CEA.
Thank you for joining the AAN Resident Lecture Series. A recording of today's webinar will be available on the AAN's YouTube channel. Dr. Pawa and Dr. Azim, thank you for presenting today. Thank you everyone for joining. Have a good day.
Thank you so much.
Thank you for having us.